very much. Thank you for having me. I'll try to give you the information in a nutshell for radiation. So we divide between brachytherapy and teletherapy. Brachytherapy is a contact treatment. Teletherapy is a projected treatment. We use in brachytherapy different radioisotopes, ruthenium, iodine, and others. And in terms of teletherapy, it can be provided either by protons or by projected and accelerated photons or electrons. There is a difference in the biological and the physics of these different kinds of radiation. Proton beam irradiation has a very steep dose distribution, the so-called Bragg peak that we use, whereas photons don't have that. So we need to make physics work on that in order to avoid this distribution at the end of the tissue. Ruthenium has a very steep dose distribution, therefore is very helpful for treating tumors up to a thickness of approximately 6 to 7 millimeters, as you can see here. So ruthenium is a high energetic beta irradiator, has a half-time dose of approximately 1 year and is suitable for treating tumors up to 6 to 7 millimeters. This is the experience in Essen. We use to calculate the prescription point is about to the apex about 120 grays, 120 to 130 grays, and there are some other cases as well, obviously, and at least 700 grays at the sclera dose. There are different calottes that you can use, some that are notched, as you can see here, for the optic disc or for the cornea. Another example. And in contrast to ruthenium, there is the iodine brachytherapy that is a low energetic gamma irradiator that is usually and commonly used in the United States. It has a half-time of 2 months, and the dose distribution is different, so you can use this calotte iodine isotope for larger tumors, up to 12 millimeters. You see the differences in the isodose distribution between the ruthenium calotte here and the iodine calotte on the other side. On the other side, you have also more distribution to the opposite side of the eyeball, so there are more complications in terms of radiogenic side effects from the iodine plaques. The way we use the plaques is to do a transillumination, as you can see here, then mark the area of treatment and apply the calotte, as you can see, and control the placement of the calotte, as you can see here. In the very first period of treatment, on long time follow-up, the local control rate, the eye retention rate was better than 90%. In the last 10 years, it became even better with 97%. In terms of local tumor control, up to 90% on 10 years, and in the last 10 years it became better with 96% of long-term local tumor control. Metastatic rate in these cases is about approximately 13%, different than what Jens just told you, because these are smaller tumors, so they are the T1, T2 tumors. In terms of radiation optic neuropathy, you see an increased incidence of neuropathy in the first 3 to 4 years. Similar radiation retinopathy that increases by time. And radiogenic cataract obviously is a problem. And obviously you can you must tell your patients that they will continuously have a high probability of losing visual acuity by time, and this never stops basically. So I'll share with you some examples of this treatment. You see after 3 months, the beginning of the scarring of the plaque, and after 9 months, atrophy of the choroid, and after almost 10 years with a notched plaque here, a very good result. But you must be careful not to miss recurrences, which are not very common, but you see here a situation where you had a relatively small plaque for this tumor that had a peripheral nose, And you see the recurrence of this area because it was not covered by the plaque completely. In contrast to that, we have the projected treatments, and this is the Gamma Knife, which is a projected stereotactic radiosurgery, where you have a center of irradiation. Usually the prescription point is about 20 to 25 grays in a single shot. CyberKnife has also been used in some centers, which is slightly similar to the Gamma Knife, but most centers worldwide, in terms of projected teletherapy, use proton beam irradiation, where you use protons in order to irradiate an area that needs be covered by the radiation, and to try to avoid irradiation to critical structures like the optic disc and the macula. So we use collimators and a modulator in order to avoid irradiation of the optic disc. This is a setup. It is a cyclotron that is needed. You need to, in the setting up to date, you need to do surgery before that in order to mark the area of irradiation by tantalum markers. And then the radiation dose usually used all over the world is 4 times 15 cobalt gray equivalents. In the United States, some centers use 5 times 14 cobalt gray equivalents. The local tumor control is excellent. Metastatic rate is the same. Eye salvage is about 90% in our center, and it's dependent on whether you have a irradiation to the optic disc, if you see radiation maculopathy and optic neuropathy. After almost 10 years, you don't see the same scarring as in brachytherapy, and you can have better visual acuity in long terms in some selected cases. The recent innovation is a 3D irradiation planning system that can be used, where you have a hybrid irradiation system between CT scans and MRIs. Recent development is the induction of fractionation in teletherapy, and there are, in terms of proton beam irradiation, there are different setups around the world, and it's difficult to compare them. I don't have the time to go into detail here, but this is just to show you that the distal dose of is not similar in all areas, and it depends on that, on what kind of long-term results you will get. In a very nice comparative study between protons and fractionated stereotactic radiotherapy, local tumor control was the same, but there was a higher incidence of vitreous hemorrhage after fractionation radiotherapy. And I will close with that. Thank you very much.
I think we have time for a very short question on radiotherapy. Okay, we have one. Please be short.
Is there a difference in the incidence of toxic tumor syndrome after proton beam compared to Gamma Knife?
This has not been examined, but my opinion, if you want my opinion, I don't think there is any difference.
Okay. One more.
Because it is dependent on the tumor size, not on the radiation type.
One last question more. After brachytherapy for juxtapapillary tumors, I noticed that the incidence of recurrence is higher, especially around the optic disc. Any clues to avoid that?
Well, if you use plaque therapy and you have circumpapillary infiltration, it's difficult to address all areas. But if you do a projected treatment, obviously you can irradiate the entire optic nerve, yes, or optic disc.
So just a small comment about the juxtapapillary is that inside of the eye, the optic nerve is about 1.5 millimeter. On the outside of the eye, the optic nerve is about 6 millimeter. So there's a difference between where you can put the plaque and what you actually see inside of the eye.
That's right.
Thank you. So yesterday we heard Bertul D'Amato introducing the term OncoVR ophthalmologist.